Because of the population density, because of the sanitation, it's like a 5-star hotel for the virus.
इसका बुखार बहुत तेज था। जब वो डॉक्टर से वापस घर आया तो दोनों पाँव उसके काम नहीं करते।
बकाया है अल्लाह देशो खपल बदन न मगुर देगा ना खपल बदन खपल।
If we do not take care of the virus, you can forget about the eradication.
पोलियो वर्कर्स घर घर जाकर बच्चों को इंसदाद पोलियो के कतरे पिला रहे थे।
3 people were shot.
यहाँ पे जो है ना भांजी मेरी आई है, उन्होंने दरवाजे को दस्तक दी है। ये फायर हुआ था ये यहाँ पे।
All 3 are died.
This is not supposed to be a war. These killings come from misconceptions.
باقي كده وجه ده جناقي ده وقنا مخي بالغ أو على كان جكم دينه.
The threat to the polio workers is a huge problem.
If it continues like this, then there is a risk for the country and there is a risk to everywhere else.
जगह पे टारगेट किलिंग है हर जगह पे।
To change the perception of those who want to do harm.
It's a very difficult task. It is not an impossible task.
ये program, ये तारीखी है.
The security plan is more robust than anything that you contemplated in the past.
The survival कोलो द पारा जंग दी.
आज से इंशाल्लाह अपने मशीन को जारी सारी रखसा।
और इसमें हम मुकम्मल तौर पर प्रोटेक्शन देंगे अपने रज़ाकार।
हमारा मसीह दुआ है कि अपने पाँव के साथ खड़े हो जाए।
You proved everybody wrong by going back and really immunizing those children.
इंसान ज़िंदगी दा सीधा लगा हवा चिट्ठी रही है ना। अब दे दुनिया गोड़ी हम गाना पर दुनिया में इंशाल्लाह रोको।
और जो लोग इन्हीं चाहते कि बीमारी खत्म हो, वो लोग इंशाल्लाह नाकाम हो जाएं।
Good afternoon, and thank you for joining us. I'm Dr. Phoebe Thorpe, and it's my pleasure to welcome you to this Public Health Grand Rounds on global polio eradication, reaching every last child. And thank you for those of you who are joining us outside of CDC and those who will be joining us later. Public Health Grand Rounds is available on the website and social media sites too. We have a featured video segment beyond the data that you can see shortly after this session. Continuing education credits for Public Health Grand Rounds are available for physicians, pharmacists, nurses, epidemiologists, health educators, and others. Please see the Public Health Grand Rounds website for information. We are also tweeting today, so please use hashtag CDC Grand Rounds for all your tweeting needs. We have partnered with the CDC Public Health Library and Information Center to feature scientific articles that are relevant to the polio eradication efforts. Please see the full listing at cdc.gov/library/SciClips. Here is a preview of the upcoming Public Health Grand Rounds session. Please join us live or on the web at your convenience. And for those who can stay, today at 3 p.m., there will be the documentary of the trailer that you just saw shown in this auditorium. In addition to our outstanding speakers, I'd also like to acknowledge the important contributions of the individuals listed here, especially the photographers whose photos convey a sense of the challenges faced in the field. And lastly, I'd like to acknowledge the many people across the globe who dedicate themselves to eradication of polio. Thank you. And now I would like to introduce CDC Director, Dr. Thomas Frieden.
Almost exactly 5 years ago, it was January 21st, 2010, we had public health grand rounds on polio eradication in India. At that time, it didn't look like we were going to succeed in India. It looked like either the vaccine wouldn't work well enough or we couldn't reach the areas that needed to be reached. But India proved to the world that it could be done, and if, quite frankly, it can be done in India, it can be done anywhere. Over the past year, we've seen remarkable progress in Nigeria, and because of that, we have the prospect that maybe Africa is now free of wild poliovirus. If it's not free of wild poliovirus, it's very close to being free of wild poliovirus. In terms of the number of people who've been reached, in terms of global partnerships, the Global Polio Eradication Initiative is the largest public health program ever. There's a very robust partnership with CDC, WHO, Gates Foundation, Rotary International, UNICEF, and many other partners in individual countries and around the world. It's a program that has been extensive and expensive, and it has now reached a decisive moment, a dangerous moment, and a moment where we are closer to polio eradication than ever before in human history. You'll hear about what led to some of the progress in Nigeria. And ironically, as we sit here today, some of that progress was patterned after successful progress in Pakistan. You'll hear of the challenges, progress, and more challenges in Pakistan. Polio eradication now faces what may be its biggest hurdle yet: violence specifically directed against polio vaccinators. This is territory that is dangerous, it's tragic, it's heartbreaking. And we face a real dilemma. Do we, on the one hand, go forward to try to protect every child in the world from now on forever by achieving eradication with the risk that there could be more murders? Or do we back off and risk not only hundreds of thousands of children being disabled for life, but also not honoring the struggles of those who were harmed or killed in the effort for eradication? That's a decision which each individual who is involved in the effort needs to make for him or herself. But we know that the world, led by frontline vaccinators, community health workers, supported by a robust global coalition, is close to eradication. And we know that the momentum that leads to eradication is something that is very powerful. We also know that some of the things that led to the progress in India and in Nigeria were not focused on polio. They met communities where the needs were most acute and most felt. They addressed needs for health, water, sanitation, education, information, and that kind of approach by indirection is likely to be critical for this last mile. So I'm delighted to have wonderful speakers, two of them from work within the countries that are most affected, for us to learn from and have the opportunity to interact with in this public health grand rounds. Thank you all very much.
Thank you, Dr. Frieden, for your inspiring words. And all right, now I'd like to introduce our first speaker, Dr. Gregory Armstrong.
There we go. Okay, thank you, Dr. Thorpe and Dr. Frieden. So I'm Greg Armstrong, Chief of CDC's Polio Eradication Branch. Before we start, I'd like to introduce some terminology for use throughout today's presentations. We'll be discussing two classes of virus, wild poliovirus and vaccine-derived poliovirus, two types of vaccine against polio, the oral poliovirus vaccine, OPV, and the inactivated poliovirus vaccine, IPV. In discussing vaccination strategies, we'll distinguish between routine childhood immunizations and vaccination campaigns, also called supplementary immunization activities, or SIAs, which in any country can be national NIDs or subnational. We'll discuss two types of surveillance: surveillance for acute flaccid paralysis to find polio cases, and environmental surveillance to find circulating virus. I'd also like to touch on two topics that we won't have time to discuss in any depth today. The polio endgame, logistically complex preparations already underway globally to prepare for a world without polio, and vaccine-derived polioviruses, which are phenotypic reversions of oral polio vaccine viruses and which are of increasing importance to the eradication program. Circulating VDPVs are only seen where immunization coverage is exceptionally low. The work we will be presenting today is that of an extensive global partnership, the Global Polio Eradication Initiative, headed by national governments with 5 leading partners: Rotary International, the World Health Organization, UNICEF, CDC, and the Gates Foundation. Polio is caused by one of 3 viruses of the genus Enterovirus, designated Poliovirus 1, 2, and 3. Polio is highly infectious, with virus found in oral secretions and stool. Prior to the availability of vaccines, polioviruses were ubiquitous with a global distribution. Clinically, most poliovirus infections are asymptomatic or not recognizable as polio. At most, about 1 in 200 infections results in acute flaccid paralysis. Severe bulbar polio can be fatal. Vaccines against polio first became available in 1955 and resulted in dramatic reductions in polio in the United States and elsewhere. However, more than 3 decades later, by 1988, polio vaccines remained beyond the reach of many of the world's children, resulting in more than 300,000 cases. That year, the World Health Assembly adopted a resolution to eradicate polio globally by the year 2000, initiating what has become the largest global public health program in history. The first decade of the program was highly successful. Cases decreased in the 1990s by over 99% globally. Polio was eliminated completely from the Western Hemisphere. And one of the 3 polioviruses, type 2, was eradicated. However, the goal of eradication by the year 2000 was not achieved, and the program entered a decade during which global case counts stagnated. The program struggled with setbacks, including outbreaks. And in India, nothing seemed to be working. While this appears to be a lost decade for the program, in reality, it was a decade of innovation, both technological, such as more immunogenic monovalent and bivalent oral vaccines, and programmatic, including innovations to reach chronically missed children. This brings us to 2011, a pivotal year for the program. January of that year saw the last case in India, erasing any doubts about the technical feasibility of global polio eradication. However, at the same time, case counts had increased in the remaining 3 endemic countries: Pakistan, Afghanistan, and Nigeria. That October, the program's independent monitoring board released an unreservedly critical report concluding the program needs greater global priority and further funding. Failure would be a disaster. We are convinced that polio can and must be eradicated. We are equally convinced that it will not be eradicated on its current trajectory. This report had a profound impact on the program, moving it into its current emergency phase. In response, the partnership undertook a major revision of its strategic plan and a scale-up of resources, including staff. At CDC, Director Tom Frieden moved the program to the Emergency Operations Center. So where does polio eradication stand at the beginning of 2015? First off, you'll notice that there are no blue dots here, no wild type 3 cases. The last known case was over 2 years ago, and it's quite possible that type 3 has been eradicated, leaving type 1 as the only wild poliovirus type in circulation. In Nigeria, you'll notice that there haven't been any wild polioviruses in the last 6 months. The last known case there was in July, and while it's too early to know whether polio has been eliminated there, this represents a major achievement. We'll hear about how Nigeria managed to turn a failing program into a model of coordination, responsiveness, and innovation. Next, Afghanistan and Pakistan. In reality, Pakistan is the source of most of these cases, since many of those in Afghanistan represent importations. Pakistan is now in the midst of a large outbreak of polio. This is a major setback from the situation in December 2012, when the country, after 2 years of reforms, was set to eliminate the virus. That month saw the beginning of violence against polio workers, from which the country is now only recovering. We'll hear more about this later. Finally, I'll highlight 2 recent polio outbreaks centered in Syria and Somalia, where the program has had to adapt to very insecure environments. In fact, insecurity is the common thread in all 5 of these polio-affected countries just mentioned. I'd also like to highlight what you can't see here: an enormous global infrastructure supported by the Global Polio Eradication Initiative to keep the rest of the world polio-free while polio is eliminated in the remaining reservoirs. The GPEI so far has spent almost $12 billion, and is now spending almost $1 billion per year. To understand the rationale for such a large investment, we have to understand what's at stake. What would happen were the polio eradication program to fail and this global infrastructure to suddenly collapse? A temporary boycott of polio vaccination in northern Nigeria in 2003 gave us a glimpse of what this might look like. That boycott caused a sizable outbreak in Nigeria, which spread to 8 previously polio-free countries by the end of that year. Eventually, 20 countries were reinfected before these outbreaks were extinguished. On this map, the arrows show instances over a 12-year period where poliovirus crossed international borders to cause outbreaks. Polio is clearly a pathogen that spreads globally with ease. We can say with some confidence now, in 2015, that were polio eradication to fail, poliovirus would quickly spread internationally, causing large disruptive outbreaks, the response to which would require substantial resources. Poliovirus would find its way back to every country in the world with inadequate immunization coverage, eventually causing 200,000 cases per year. Alternatively, successive polio eradication will bring enormous benefits. Through 2012, the program had already prevented an estimated 4 to 6 million cases at a cost of about $1,700 to $2,500 per case prevented, even without accounting for savings in medical costs and lost productivity. However, the real benefits from the program accrue once eradication is achieved. According to one study, eradication will result in 2 million cases prevented over the first decade after completion and tens of billions of dollars in savings, even after covering the full costs of the eradication program. Furthermore, the benefits of eradication are forever and are equitable. Looking at smallpox, the only human disease to be eradicated, the number of cases among children in Somalia and Syria last year, or in the last 3.5 decades for that matter, was exactly the number among US children, 0. If you'd like to learn more about these issues, please visit GPEI's website at polioeradication.org. Thank you, and I'd like to introduce our next speaker, Dr. Steve Oberste.
Good afternoon. I'm Steve Oberste, Chief of the CDC Polio Laboratory. Dr. Armstrong just described the status of polio eradication efforts, but how do we know what progress has really been made? Surveillance is the key to telling us where, and importantly, which polioviruses are still circulating. The goal of surveillance is to detect wild and vaccine-derived polioviruses. We monitor for cases of acute flaccid paralysis, or AFP. However, AFP is not specific for polio. That's where the lab comes in, to determine whether the AFP is caused by poliovirus. Polio can be excreted in the feces for several weeks after the onset of paralysis, so stool samples are collected and sent to an accredited laboratory for analysis. In some parts of the world where AFP surveillance is suboptimal, other surveillance systems are also used to supplement AFP surveillance. So testing of sewage is especially important in some areas and is increasing in priority. The general approach is to take a stool extract or concentrated sewage sample and place that in cell culture. If the virus is present, it will kill the cells. Then sensitive molecular assays are used to detect the poliovirus genome and to determine whether the poliovirus is vaccine-like, vaccine-derived, or wild, a process that's termed intratypic differentiation, or ITD. Partial genomic sequencing is then used to characterize wild and vaccine polioviruses and to determine their relationships to other known polioviruses. There are 146 laboratories in the Global Polio Laboratory Network, or GPLN. The network is coordinated by the World Health Organization with technical support from CDC and some other major public health institutions worldwide. The global and regional polio laboratory coordinators are critical to its smooth functioning. Many of these expert virologists are former polio lab directors themselves. Every country is served by at least one polio laboratory. Laboratories may perform a variety of tests depending on their capabilities and polio risk in their area, from virus isolation only to isolation and ITD to isolation, ITD, and sequencing. The 7 global specialized laboratories perform additional reference, training, and research functions on top of the basic diagnostics. With such a heterogeneous and geographically dispersed network, there are considerable challenges. Many of the laboratories are in resource-limited settings with frequent power outages and difficulties in importing supplies and shipping specimens. The laboratory workload has been steadily increasing over the years. Over 200,000 stools were tested in the GPLN in 2013. Staff turnover is also a major concern, as experienced staff are lost and new staff must be recruited and trained. All these factors can affect the laboratory quality and turnaround times. However, technical innovation has led to new diagnostic tests and new algorithms have been introduced to speed up reporting, to improve sensitivity and specificity for poliovirus detection, and to add new capabilities. A number of advanced molecular assays have been developed to detect and characterize polioviruses, and new technologies have been applied as they become available. These include highly specific assays to detect wild polioviruses and the use of new commercial reagents to drastically increase sensitivity so that we do not miss important viruses. FTA cards are impregnated with a chemical that inactivates viruses. Their use allows virus isolates to be shipped at ambient temperature and as non-infectious material, reducing shipping costs by more than 10-fold and facilitating shipping from countries that are otherwise prohibited from shipping infectious materials. New assays and new algorithms have also dramatically reduced the timelines of reporting for laboratory results. About 10 years ago, virus isolation could take 28 days. But new cell lines and a new algorithm reduced the time by half. Similarly, new ITD methods reduced the reporting time from up to 28 days to only 7 days. Until recently, there was no reporting time standard for polio sequencing, but introduction of standardized methods has allowed us to set a standard now of 7 days. In actual practice, most testing seldom takes as long as the timelines allow, but the longer timelines help account for high workloads and occasional difficult samples. There's also active research to improve on the laborious methods that are currently used to concentrate sewage for further processing, as well as in expanding the genomic sequence that is routinely obtained to improve our ability to track the virus transmission. Direct detection of poliovirus genome in stool and sewage without the need for cell culture isolation would reduce the time to result by 1 to 2 weeks, but it may be difficult to implement in all laboratories. Key to the success in the GPLN is the laboratory accreditation process that is overseen by WHO to ensure that the quality and reliability of the laboratory results on which the programmatic action depends. Accreditation requires an annual paper review with an on-site review every 3 years. Accreditation requires an annual, reviews include verifying data and assessing whether resources are adequate to support the lab, including reviewing staffing levels and the facilities. Is the equipment maintained? Are the reagent stocks sufficient to support the current workload? And of course, strong management is always essential. The quality of the work in the laboratories is also reviewed. Key indicators used include the minimum number of samples needed to maintain proficiency, and annual proficiency testing programs help ensure that the results are accurate. Once polio has been eradicated, we'll leave behind a laboratory infrastructure and culture of quality that can then be applied to other global public health priorities. The same principles that I just described have already been applied to laboratory networks for several other important vaccine-preventable viral diseases. The global laboratory capacity built by the GPLN over the past 25 years will be a lasting legacy. So thank you, and I'd like to introduce our next speaker, Dr. Faisal Shuaib, who will talk about Nigeria.
Good afternoon. I'm Faisal. I'm the Deputy Incident Manager of Nigeria's Emergency Operation Center. Today, I'll be talking about how the polio program in Nigeria was transformed. Prior to 2012, Nigeria's program was poor performing. There were a lot of numerous problems, ranging from ineffective vaccination campaigns, inefficiency, and a general lack of accountability in the program. In October 2012, there was a program review. This program review identified structural weaknesses, such as a lack of engagement of the federal government, poor coordination of development partner agencies. There was also poor supervision of field staff and a lack of this shared sense of emergency. Following this review, an important consensus was reached between the federal government and partner agencies. And this led to the establishment of the National Polio Emergency Operations Center at the capital, Abuja. This EOC, as we call it, led to increased engagement of the federal government, improved partner coordination, and also led to the joint development of one plan, the National Polio Emergency Action Plan. Following the establishment of the national EOC, state EOCs were also established in selected high-risk states. The EOC had the commitment of the federal government in terms of the appointment of the incident managers from the public sector. The EOC employs a data-driven approach which emphasizes data-based decision-making. So once data is analyzed, we look for gaps, and then we prefer innovative solutions. Some of the gaps that we have noticed range from the poor quality of supplemental immunization activities due to inadequate preparations, inefficient execution of the SIAs. We also observed there was poor access to underserved populations, such as nomadic tribes who live in hard-to-reach areas along interstate borders. So immunization teams were not reaching them adequately. We also observed that there was low demand for vaccines. There was non-compliance due to anti-OPV campaigns from religious clerics. Overall, there was also a lack of accountability on the part of the field staff. Once these gaps were identified, the EOC team agreed on the strategies to overcome these challenges and implemented many innovations. However, today I'll be covering 6 of these innovations, which I think were the game changers. Most of these innovations actually had funding and support from the CDC, and for this, the EOC and the government of Nigeria are appreciative. First of the six innovations that I'm going to talk about is the use of the dashboard. The dashboard is a system that collects data or indicators, critical indicators that measures the preparedness for an upcoming campaign. Now, these indicators are focused on very key activities such as micro-planning, logistics, training, and social mobilization. These data are displayed in a dashboard format using stoplight colors. So it is very clear to everyone looking at this dashboard what the issues are. These indicators are reviewed at LGA, that is the district level. They are reviewed at the state and the national level, and then any gaps that are observed are quickly closed. The indicators are looked at pre-specified intervals, 1 week, 2 weeks, 3 weeks before the campaigns. Now, this is an example of the dashboard. You can see that on the left column, the LGAs, or the districts, are listed on the left. Across the top, the most critical indicators for success. Without going through the details of the data that's presented here, you can see which indicators are being met in green and those that are not being met in red. The second innovation is the creation of the National STOP Stop Transmission of Polio program in Nigeria. This is a workforce of locally trained field epidemiologists who provide technical expertise at the LGA and the state level. The NSTOP is involved in providing technical capacity building at the district level for routine immunization. They give support to the polio campaigns and are involved in outbreak response. They also are involved in operational research in collaboration with the Nigeria Field Epidemiology and Laboratory Training Program. In 2012, we observed that nomadic and other underserved populations were potential risks for transmission of poliovirus. The CDC NSTOP team conducted a census of settlements and children that were being missed in previous SIAs. Now, by May 2014, over 1.5 million children had been identified and vaccinated by this program. The fourth example of our innovation were the health camps. These were targeted at meeting the unmet felt needs of communities. It was targeted at addressing non-compliance. So a fixed post is set in a high traffic area in some of these high-risk communities. They provide routine immunization, including oral polio vaccine. They treat common ailments, and also provide health screening. To provide additional support to poorly performing districts, management support teams were deployed. These teams provide guidance and technical support to resolve management challenges, coordinate field work, and provide advocacy messages to local leaders. A final example of the need for ongoing innovation is the deteriorating situation in Borno State, which is home to the Boko Haram insurgency. Since May 2014, the inaccessible red areas has grown, as you can see, and now over 60% of settlements are inaccessible to vaccination teams. The worsening situation in Borno and Yobe meant we needed specific strategies to reach children while keeping health workers safe. The strategies that we deployed include a modified rapid SIAs or hit-and-run strategy to quickly conduct activities when an area becomes accessible and then leave the area so as not to draw unwanted attention to our staff. We increased vaccination at border crossings and transit points. Since May 2014, over 2.5 million OPV doses have been administered in Borno and Yobe states. Now, what are the results and impacts of these interventions? After campaigns, LQAS, or lot quality assurance sampling, a standardized sampling method, is used to assess coverage. The LQAS in Nigeria samples target populations of children at the LGA level. Finger marking is indicative of OPV receipt. Success or failure is based on the number of unmarked or missed children found. This chart shows OPV coverage over time using LQAS data. We've made great progress, as you can see. In September 2013, 39% of LGA sampled reached over 90% of the children in their areas. By December 2014, 74% of the areas reached 90% of children. You can see that we're getting close to reaching every last child. We had big problems in the program. We pursued all of these innovative activities. The EPI followed. Now look at how we haven't seen a single case of WPV3 in over 2 years. And we've not seen a single case of WPV1 in over 6 months. This is the first time ever this is happening. The polio program has also reached beyond polio eradication. Implementing EOC strategies has strengthened public health infrastructure. It has strengthened routine immunization. It has allowed for training of more health workers and has been credited with the rapid containment of Ebola outbreak in Nigeria. Nevertheless, challenges remain. The security situation in the north is particularly troubling. This has made it impossible to access some settlements, created large numbers of internally displaced persons, and thereby limited PEI activities. Persistent CVD-PV circulation in some states gives us cause for concern. Furthermore, with upcoming general elections, there's a risk that political office holders will divert their attention away from polio eradication activities. In 2015, we hope to stop the transmission of WPV1 and CVD-PV. We will focus on closing the immunity gaps by strengthening routine immunization. We plan to introduce IPV, especially in the high-risk states. Of course, we'll continue to conduct surveillance for acute flaccid paralysis and hope that July 24, 2014 represents the day when the last child in Nigeria contracted wild-type poliovirus. Now, none of this progress, none of this will have been possible without the folks pictured here. Thanks to them for their hard work, their commitment and dedication, we can really dream about stopping poliovirus by reaching every child in Nigeria. Their commitment is very central to what we've been able to achieve. Now I'd like to introduce Dr. Elias Duri, who will give the next talk. Thank you very much for your attention.
Good afternoon, everyone. I'm Dr. Elias Duri, WHO Senior Coordinator for Polio Eradication in Pakistan. This slide provides a quick overview of the Pakistan polio program's evolution since its inception in 1994. Between 1994 and 2005, there was a dramatic decrease in the number of polio cases. In 2005, only 28 cases were confirmed. But in 2008, there was an upsurge in cases, and the case count reached almost 200 in 2011, the highest globally for that year. This led to the launching of the National Emergency Action Plan in December of 2011 that contributed to a significant decrease in the number of cases in 2012. However, since then, the number of polio cases have been on the rise and reached 306 in 2014 for reasons I shall describe later. During its long history, the Pakistan polio program lacked government ownership and accountability at all levels. Financial misappropriation was easy, resulting in phantom or inappropriate vaccination teams and inclusion of children in the teams. This affected the quality of the fieldwork substantially. Insecurity in FATA, an area that borders Afghanistan, cannot be ignored either. These problems were the highest in key reservoir areas of FATA and bordering KP, another Afghanistan bordering region of Quetta Bloc, and the biggest metropolitan city of Karachi in the south. With 198 polio cases in 2011, global pressure was mounting on Pakistan. This pressure led to the development of the 2011 National Emergency Action Plan that brought an enhanced oversight and ownership by the top leadership at all levels. The Prime Minister followed the program personally through regular national task force meetings, and the same at provincial, district, and sub-district levels. Through newly devised comprehensive dashboard metrics, it was possible to conduct regular review meetings before and after every campaign, chaired by the top leadership. Under the plan, all districts in the country were prioritized to develop appropriate strategies for each area that with different degrees of risk. WHO and UNICEF scaled up their support through surgeon staff. At the same time, multidimensional innovations also came in. Short interval additional dose strategy of conducting campaigns with an interval of 7 to 14 days was heavily utilized to cut down viral lifespan rather quickly. Direct payment by using banks was also introduced to ensure complete and timely payment to the frontline workers who must be above 18 years of age. As a consequence of the implementation of the emergency plan, by the end of 2012, cases were reduced by 71%. There was significant reduction in viral circulation in major and stubborn reservoirs like Karachi and Quetta Block, and the circulation was geographically restricted to FATA and KP. Furthermore, type 3 polio virus transmission was interrupted. The case in April of 2012 turned out to be the last type 3 virus in Pakistan and also in Asia. At the advent of the low transmission season of January to April of 2013, everybody thought that 2013 will see the end of polio in Pakistan. But that was not to be. Things started derailing in 2012. The first bad news was the absolute ban on vaccination imposed in June in North and South Waziristan of FATA through a written intimation by the local elements as a protest against drone attacks, as well as labeling vaccinators as spies. In the following month of July, a WHO polio worker was killed in Karachi, followed by a series of threats and attacks on frontline workers. The full-blown serial attacks started in December of 2012 and went on in 2013 and are still going on. Unfortunately, the majority of these attacks happen in reservoir areas where polio was circulating. So far, more than 60 frontline polio workers as well as security personnel were killed. The latest one being just 2 days ago in Quetta Block. 2013 was a year of stagnated polio eradication efforts in Pakistan. The new unprecedented reality of direct attacks and killing seriously compromised the scope, the quality, and the quantity of campaigns. Frontline polio workers became demotivated and scared of losing their lives. In an effort to conduct vaccination under the security cover, typical 3-day campaigns were broken up over 3 weeks, taking away the effectiveness. Multiple campaigns were missed or were of poor quality because of insecurity. The gains made in 2012 were almost reversed, and the program was in a state of despair. Consequently, almost all cases in 2013 came from the areas with insecurity and barriers to immunization. In 2014, the poliovirus circulation continued to intensify in these areas. The fact that more than 75% of polio cases in 2014 came from areas with barriers to vaccination clearly indicates that insecurity is the largest challenge of polio eradication in Pakistan. Let's take a look at some of the strategies used to overcome insecurity. Because of the unprecedented challenges, security planning became an essential component of polio eradication initiative. Special operational and security guidelines were developed. Law enforcement agencies became the part of polio eradication structure at all levels. One good example of an innovative initiative to mitigate security security challenges in a threatening environment is a special protected campaign conducted in Peshawar, the capital city of KB, and bordering FATA in early 2014. The fear and challenges that prevail over the entire 2013 were broken by a substantial joint effort by the provincial political and administrative leadership, the law enforcement agencies, and partners. A program called Justice for Health was run for consecutive 12 weeks from February to April 2014. Polio vaccination was performed with innovation in 3 main areas. First, operationally, the initiative was not labeled polio. Rather, it was rebranded as a comprehensive health package with routine immunization, with medical camps and health education included. The campaign operation was modified from usual 3 days approach to 1 day to minimize exposure. In this effort, more than 5,000 volunteers were mobilized to reach around 750,000 children on 12 occasions. Second, the communication. There was a state-of-the-art extensive communication and mass media campaign with heightened visibility to support the operation and to reverse the misconception about the program. Third component was the cordoning security measure that I will describe later. Next. Security needed intense and meticulous work. The approach of security personnel accompanying polio workers had not been successful in 2013 and rather put the security personnel at risk. Hence, a cordoning approach was devised together with a series of steps, including security zoning, pre-campaign targeted intervention and reconnaissance, plugging points and special checkposts, mobile patrolling, ban on motorbike riding, and limited cellular phone services during the campaign day. All these interventions require huge numbers of police and security personnel. The gains were substantial. First and most importantly, not a single life was lost, while more than 8 million OPV doses was administered over the period of 12 weeks. From an epidemiological perspective, for the first time ever, Peshawar had a flurry of negative environmental samples from April through August 2014. Furthermore, most of the polio cases from June 2014 onwards in Peshawar were because of viruses imported from other places. The military operation in North Waziristan of FATA that was initiated in mid-June 2014 and displaced nearly 1 million people from the tribal agency to the neighboring areas created a breakthrough opportunity for the program to reach those who were deprived of vaccination for over 2 years because of the ban. Multiple strategies were utilized to reach the displaced population. Fixed transit vaccination posts were established to check at checkpoints to immunize not only the kids, but adults to boost population immunity instantly. More than 1 million individuals have been vaccinated so far by this effort. During the start of the operation, as many as 44,000 individuals were vaccinated at a vaccination post right at the border of North Waziristan in a single day. Another effort was to reach children among the displaced population in the hosting communities. Multiple campaigns were conducted with much effort to identify, map, and track the displaced population. Recently, limited activities were also being conducted within North Waziristan itself. The military operation in North Waziristan also opened an opportunity to reach children in the neighboring region of South Waziristan, where polio eradication is also banned. For the first time in 2 years, South Waziristan was reached with multiple campaigns since November 2014, vaccinating more than 70,000 children. This indeed is another breakthrough. Since June 2012 till early November 2014, multiple efforts were made with alternative strategies, but could never reach a significant number of children. Reaching kids from both North and South Waziristan are huge news, not just for the national program, but also for the global eradication initiative. The last case of polio in North Waziristan was in September 2014, and the number of cases in South Waziristan is declining. In addition to a provision of security through protected campaigns and using every opportunity to reach the unreached, a lot of work has been done to gain negotiated access through religious leaders and engagement of the community itself. Moving forward, in November 2014, a national planning workshop was conducted, taking into account basic security planning in addition to operations and communications. The plan is consistent with the National Emergency Action Plan and is formulated in the light of all experiences of 2012 and 2014. However, adequate implementation of this plan is a challenge and will need coordinated effort by all arms of the government. While critically looking at where the program stands today, it's a mix of a positive and worrying situation. Peshawar is continuing to its pattern of one-day SIAs and trying to find ways to improve quality and reach more and more children. After a long time, children in North and South Waziristan of FATA are being reached. On the other hand, Karachi seems to be struggling to achieve quality campaign. Security threats and incidents continue, and the security provision is not up to the mark. The ongoing operation in Khyber of FATA also seriously compromising access to children in the middle of an ongoing outbreak. In conclusion, We know that Pakistan has contributed 85% of global cases in 2014, and the country, together with Afghanistan, is expected to be the only infected place globally in 2015. The real challenge in Pakistan is that polio continues to be a weapon of the anti-government elements to pressurize the government. In fact, due to the global and national importance of polio eradication, the extremists seem to be focusing more on using polio as a weapon against the government. Hence, we can easily say that polio is not incidentally caught in the crossfire, but it is at the forefront. This is an extraordinary situation ever faced by any public health program globally and would need extraordinary effort to overcome the challenges nationally and internationally. Finally, I would like to conclude my presentation with a special salute to the brave vaccinators who continue to get out to the streets despite the tremendous security risks they are facing. Since the dreadful December of 2012, they have administered more than 500 million doses of OPV. No doubt that the world will remember the martyrs who lost their life and appreciate the ones who continue to participate in the most dangerous work in Pakistan today. Thank you.
Thank you. We do have a limited amount of time for questions. I'd like to ask members of the audience to please come up to the microphones and to please keep your questions brief in the interest of time. We'll also be taking questions from social media. Sorry, go ahead from social media.
Yes. So is acute flaccid paralysis wild polio or vaccine-derived polio? Please explain.
So I can take that one. The way we do surveillance for polio is to do surveillance for acute paralysis, acute flaccid paralysis, and that can be caused by anything. In fact, in the absence of polio, there are a number of things that do cause acute flaccid paralysis. It's actually one of the ways that we have of monitoring the quality of surveillance. We know that in a given country that they should be seeing a certain background rate of acute flaccid paralysis. That's due to things other than polio, due to Guillain-Barré syndrome, for example, or transverse myelitis. Both wild polioviruses and vaccine-derived polioviruses cause acute paralysis. In fact, clinically, they're indistinguishable. The paralysis that comes from vaccine-derived poliovirus is every bit as severe as paralysis from wild-type viruses. Yes, please.
Excellent presentations. During the last year, the WHO implemented new measures restricting travelers from Pakistan to be vaccinated. Is there early evidence that this is actually working to contain the virus within the borders?
Would you like to take that? All right, it's been thrown back to me. So all I can say is that we haven't documented any exportation since then. You know, in the years before that ban occurred, Pakistan had exported polio to China, to Syria, Egypt, the West Bank, and I may be missing one or two. Iraq, yeah. So it's I think still too early to say how much of an impact it's having, but on the positive side, we haven't seen any exportations to date, other than exportations to Afghanistan.
Hi, my question is for Dr. Jury. Given the intensity of the security efforts that it's been taking to get every child vaccinated and most children vaccinated, how do you envision that these measures can continue to be made over time, and what will it take to ensure eradication, especially if you have to kind of keep doing these type of intense measures?
Now, it's very true, as you may heard or saw, the intensity of activity is really, it's a problem by itself. But I think what we try to do is really to utilize the low season, the time period where the vaccine is most effective in controlling the disease. We try to do as much as we can now and to get over it. Actually, if one thinks about it, one way of stopping all of this killing is by finishing the job. So we feel like we really need to do whatever is necessary to achieve that goal. Of course, protected campaign is only one part, but there is really a continuous discussion also with the community and by working with them without actually bringing security in so that they can do their campaign by themselves. We have a very well-working arrangement in Karachi, for example, where 1/3 of areas that are really not reachable by police is now currently is being reached by community volunteers that will go in and work there.
Another question from social media.
What, if anything, is being done for victims of post-polio syndrome?
So, yeah, I guess that's coming back to me again. It's, as we get into the end game, these questions are getting larger as to what are we going to do to reach out to people who've had polio in the past and people who, many years after the acute polio paralysis, are developing more severe disease, this post-polio syndrome. I know Rotary is working in some countries on this, but it's one part of the end game that we haven't paid a lot of attention to at this point, but is something that is certainly on the radar screen. Yes, from the center.
Yes, really great news about the prognosis in Nigeria, but there appeared to be, on the surface at least, a contradiction in your presentation. While the number of cases is dropping dramatically, you also showed that in Borno, access to children was decreasing also dramatically. And how do you explain that contradiction?
Yeah, thank you for that question. So in Borno and Yobe, where we have the insurgents, the insurgency has caused a lot of displacement of people from their communities. So while access is becoming a problem in some of the districts, community members are not just sitting down in their homes and waiting for insurgents to attack them. They are leaving those areas and going to neighboring LGAs, like metropolitan LGAs. They are going to neighboring states. They're even moving to the capital. They are in IDP camps, in camps for internally displaced persons. From our investigations, very few people are left in those settlements. That is why we talk about, decreased access to the settlements, but not necessarily decreased access to children, because most of them are not there. Nevertheless, we continue to feel pretty confident that, we're getting information around from environmental samples that show that we're not having WPV cases, in the environment, we're isolating CVD-PV cases. So if there were WPV cases, then we expect that we'll see some of them. And then I think one thing that has been very helpful was that we conducted an IPV campaign just before the insurgency really increased. And we think that helped a great deal in, stopping any type of transmission, be it white polio or CVD-PV in most of those areas.
Okay, and one last question from the audience.
Yes, thank you. For Dr. Dury, I was wondering about the motivations behind the attacks on the polio workers, and in particular, are these specific to polio vaccinators, or do they also target other vaccines like measles, or is it government health programs, or all government programs? Can you just explain a little bit more? And what is the ordinary people's reaction to this? Thank you.
Yeah, I mean, like this may be part of overall anti-government steps But within immunization itself, polio is actually the one which they go after. There are a lot of health centers where they are allowed to do other vaccination, but not polio. And you know, the reason I think is like I said earlier, probably it has been seen as one of the most important government activity that everyone is talking about. The globe is talking about it. So probably for them this may be an easy target to make a point. But I think it is also has something that comes with the misconception about the vaccine safety itself that was running around. But it is true that whichever way you look at it at this moment, by virtue of it being on the news for so long, now by itself is really a problem. So it's a polio problem at this moment.
All right, and one last question from social media.
What is the average age of onset of polio?
How long is a piece of string? It really depends on where we're looking, but in most of the areas where we work, it's less than 5. It's generally 2 or 3 years.
Answer, like when you look into Pakistan, the most of the cases are under 2 years of ages. Most of them being born after the ban of polio vaccine. So it's most of them are under 2, which coincides with the ban on vaccination.
Presentation. Thank you very much to our speakers, and thank you very much for joining us.